Sir Richard Thompson, who was the personal physician to Her Majesty the Queen and also a former president of the Royal College of Physicians. Thank you.
Thank you, Mr. Gill, and the honour is mine, I think, and I'm sorry about that terrible photograph. I'd like to support, obviously, everything that Asim Malhotra said, and I'll run over some of the things he said to support that. First of all, Peter Wilmshurst, he mentioned as a hero of mine. He literally put his house on the margin to try and fight an American company who took him to court. And he's really emphasised in my country the problems that occur, particularly among doctors and companies. Well, first of all, have you got the thing for the slides? Yep. First of all, public health. As you know, public health has improved overall our health much more than any doctors have done in terms of improving water supply and diet and things like that. But I'm particularly upset when I see that so many people spend a lot of money, billions in fact in England, on supplements, on gluten-free diet, which are completely unnecessary unless you have celiac disease, on vegan diets we were talking about on the train, and every tube station you go in London, you see great investments for vitamins that are required for teens and babies and pregnant women and old people. Complete nonsense. Very few people need vitamins. I've worked myself for many years on zinc, for instance, and zinc is very rarely required as a supplement, certainly in Europe, although in developing countries it may well be needed. Asim has mentioned alcohol and cigarettes, and I put up there the government is very reluctant, and it is very reluctant to change. I myself asked, when I was at the College of Physicians, asked Andrew Lansley, the previous Secretary of State, to stop make illegal smoking in cars, because my college had shown that secondary smoking, as Asim mentioned, is in fact a deterrent to health, much to my surprise. And he's known it's a step too far, and it took the MPs in the English Parliament to force him to do that. So they're very resistant. And of course companies are very resistant. As you know, one of the big tobacco companies took the Australian government to court in Hong Kong to try and prevent their move to have plain packaging on cigarettes. So as Asim said, the companies resist any improvement that one wants to achieve. And alcohol, which I'm very interested in as a gastroenterologist, we have argued for years to have a minimum price for alcohol to prevent the heavy alcoholics drinking cheap alcohol, which is often cheaper than water in supermarkets in the UK. But that was resisted by the companies who fought for years the Scottish government, who were trying to introduce a minimum unit price. So I'm afraid the companies are very liable for trying to prevent many of these changes occurring. And then fat and carbohydrate, I've been educated by Asim, because I used to tell my patients to stop eating too much fat if they're overweight, which of course is very effective, but actually it's not only effective but also better, as he's explained to me in words of two syllables, to reduce your carbohydrate rather than your fat. And then wrong treatment. We all know now the problems with antibiotics. It's multiple problems. It's certainly prescribed too much. I understand in parts of Europe you can get them over the counter, and we have to change that, because as you know there's a big risk of getting really completely resistant organisms such as in tuberculosis and things, which will cause a major problem, and certainly some transplant units have had to close down because of that. Asim has mentioned some procedures which are completely useless, and trials have shown that knee washouts are useless. Tonsillectomy is often useless. Cardiac bypasses and stents, as he said, and meshes, which Carl Hennigan, who can't be here today, has managed to achieve a ban on those in this country. Reminds me of the joke about nails in coffins, and that is, why do they put nails in coffins? That's to prevent medical oncologists giving any more treatment. And when you think of it, any good joke has truth in it. They do go on and on and on. If you look at the trials in the New England Journal of Medicine, there's a tiny improvement in longevity of a few weeks after many months of treatment with a lot of side effects. What are we doing giving these drugs? Someone has pointed out that we probably treat 100 patients with breast cancer with drugs in order to improve 10. We need more selective treatment. And then too much medicine, which Asim was part of that program through the Academy of Medical Royal Colleges in London, Statins, he's very big on that. I'd be very interested in alteplase for stroke, the thrombolytic agent which is given. The evidence through the trials is very poor. It's the same problem with statins. And yet when you approach the regulators, as a colleague of mine, Roger Shinton, and in England and myself have done, the medical health, the Committee of Health Medicine and so on, the MHRA as well, when you approach them, they really don't want to do it. They'll set up a sort of working party, but they'll just rubbish everything that we say. It's been very disappointing. And then there are things like gastrostomies, feeding gastrostomies, tubes going into the stomach to feed people who are not swallowing, sometimes very appropriate, but I know in my own family it happens to people with a devastating stroke, unable to swallow and are fed through a tube entirely. You wonder, what are we doing as doctors, or indeed as the public, who have to change this, to these people who should be basically allowed to die gently. Blood transfusions. I had friends who've been given the last week or two of life with cancer. Why are we doing this? Trying to keep them alive for a few more days. Partly it's financial. Some of these procedures and things are done for financial reasons, both by the doctors and particularly in the States by the institutions to get more money for their hospitals. But partly I think is because people are not prepared to say too much is going on, we must stop it. And then bad pharma. Some of you will have read Dr. Ben Goldacre's excellent book on bad pharma, which is stuffed with examples of how the big pharmaceutical companies have behaved very badly. Many treatments that are hyped turn out not to be effective. Like Asim, I talked about to the Oxford Union rather than the Cambridge Union, entitled Profits Before Patients. And they do. In the States particularly, they are basically, I think, very often dishonest. They push the benefits and completely deny the negative side effects, as we've already heard. And they lobby the government, of course, to make sure that regulation, particularly in the States, is limited. In the UK, they're trying to control that and control the prices, but because in the States it's driven by the insurance industry, it's very difficult to do so. And then playing with patents, of course, that is, if a company has a drug and it's running out of the patent period, they then suggest it might be good in children or for some other disease, and they therefore get an extension of their patent. And when the so-called confirmatory trials are done, they're often very limited, as reading on the train, very limited and not repeated in many cases. And of course many trials, even though they're published trials as protocols, turn out not to be, the results not to be published at all. And I think all negative trials should be published, as I'll say in a moment. But we mustn't forget, just due to negative, that although the things we talk about are humanitarian and benevolent, and here am I perhaps over the average age for 100 years ago, so it's wonderful I'm living longer, but it's very costly because you have to pay pensions all that time, and you have to provide end-of-life care. And the public health doctors thought that by improving care up to the end of life, you would actually cut the costs. You'd have compressed morbidity and mortality. You would only be ill for a shorter time. Sadly, that's not true. And as you know, 90% or more of the cost, average cost of medicine in your life is compressed into the last year. You come in, I think I just read in the British Medical Journal, 5 times on average each year, and the cost of those emergency admissions as a very elderly patient at the end of life is in the terms of several billion. So what you really want to know is what we're going to do about it. I have a few thoughts. As Asim said, more rigorous analysis, the number need to treat an absolute difference is very important. I think doctors particularly, I'm not expecting patients to read the papers in journals, but in fact the doctors should be much more critical looking at the papers and learn to read them. Initially I think at medical school, but also in doctors as well. Asim mentioned shared decisions, and that's absolutely right. I think patients should discuss more with doctors. Very often they say, what do you want to do? What do you suggest I should do, doctor? But nevertheless, if you mention side effects, a side effect to one person is quite different from a side effect to another. They think some things are more or less important. And the studies have shown, as he said, the amount of procedures carried out are reduced if you have shared decisions. So educate students and doctors, as I said. Tremendous scepticism of treatment. We should start by saying, do we really think this treatment works, rather than let's try it, let's give it. And most people are endlessly defending the treatment that they give. They do everything to prove that that treatment is effective, rather than saying the so-called null hypothesis, I don't think it works. What evidence is there that it does work? I'll be really critical of these things. I'm against the idea of fast-track drugs, which has come in with the FDA in the US, but also, I think, proposed in the UK. I think this is very dangerous because you never know when side effects are going to occur until it's been used. I was involved with a drug called Practicol a few years ago, which you won't have heard of, a very good drug for cardiac dysrhythmias. And it was only years later we discovered a minority of patients who got a terrible disease of the bowel, which is fascinating, but no one's shown why it occurred. And that's an extreme example. But if you shove treatment through, it's then not rigorously analysed, but well shown to be not effective and well shown to have more side effects. We should limit the lobbying of legislators. There's no doubt that the government ministers are lobbied by alcohol, by tobacco. Indeed, Lord Howe, was one of the ministers, said it was his job to see them, which I sort of accept, but I think they are much more influenced by pharmaceutical companies and alcohol and tobacco companies than by doctors. I think we should introduce the Sunshine Act in the UK. This is the act in the States where all the doctors have to declare all the money they receive from the pharmaceutical industry, and the industry has to report it, so it's all open. We persuaded the Association of British Pharmaceutical Industry, some differently, but they did agree to make a voluntary register, so they now record everything is on the web, the amount of money they've given to doctors, and the doctors themselves have a voluntary obligation to declare it. Naturally, the 20% who are not declaring it almost certainly the ones who are getting a lot of money, and we know they do receive a lot. And however much you may think you're clean and white as the driven snow, you are always influenced by this sort of money. I've had money myself from my unit many years ago. There's no doubt that you don't want to change your position. You try and support the ideas and influence that you've had. How are we going to improve the analysis of the papers? I think particularly to the specialist societies, and in my country the colleges as well, they should be the ones who look much more rigorously at what is done and put out guidelines to the members of the society, cardiac society, etc. I think we should be very wary about conflicts of interest in the regulators. The committees have been slightly involved with their role to play. There are clearly many people on the committees who are conflicted. The CEO of the MHRA, in fact, comes from pharmaceutical industry, and so does now the new deputy CMO, the chief medical officer in the UK. They may be absolutely unconflicted, I can't tell, but it's very suspicious when people have this background. Are they really going to go into the business with a clean mind? And I think, as Hema said, all drug results should be published, positive as well as negative, and particularly negative. The journals are very unkeen. They in fact should put negative trials more prominently, and the evidence is that negative trials are more likely to be right. We probably won't get onto it, but in fact the pharmaceutical companies, I think, should be influenced by shareholders because they're pension companies and they have huge returns on the stock market. We should encourage companies to use corporate social responsibility as well as just making money, and we should consider whether too many people are admitted from care homes to die when they should be dying in the care homes. And my own particular worry is we should think about assisted dying. Thank you very much.